David, just a little comment on Osaki and aortic valve repair. I was fascinated about repair about 10 years ago, because we always, I mean, it's not so easy to make a cusp like this that is closing, but we finally had our learning curve, and then we did it, and we were fascinated, and of course I was presenting the fascinated, the fabulous results for the first 2-3 years. And I was presenting that after the 5th year, and then there was a cardiologist standing up. Well, Dr. Photiadis, very nice results. I have some of your patients, and there's not a single one that hasn't been reoperated after 3 years. So I was, there was the last time that I was talking about fantastic results about aortic valve repair, and we were doing this with autologous material, the gluteal fix material. And then the outer tissue came up, so the decellularized patches came up, and it will tell you, well, nature knows the way. They will all be a cusp. So I started to do it again with CardioCell, and then they came with PhotoFix, and then they came with a new material. Now it's Matrix, and they all failed. And that's the result. And all materials will fail which are biologic, like a biological valve put in a kit will fail after 5 years' time. They are all the same. And if you look at the histology, and we did that, they all have this same material. Simply, if you have a material which is autologous and you fix that, whatever you do, the body will realize that's not the whole thing and will start to degenerate and calcify. So we gone back to ROS procedure, and we found another way, like David just told, to include it, but that's not to include the autograft, and we're now using decellularized homografts for the pulmonary valve. And we have to see what the long-term result is. Right now they're good, but we have to wait at least 10 years, and then we have the results. So still for the kids, say for the infants and even neonates, it's the most valuable option, I think, for these patients. And there is no other thing. You can try to mobilize a little bit and, as you said, get a little more mobility. But if you're forced to put a patch, that's it. that's just it. There's no single patient after 5 years that you will not operate. If you just do that as a palliative measurement to do the ROS procedure a little bit later, you can do that, but you will reoperate it. But now, sorry for this comment, I talk about mitral regurgitation in dilated cardiomyopathy. And just to begin with, I'm not a specialist in this. This topic has been given to me by Aphrodite, thank you very much. I thought, this is the black box, and it's a mean thing to talk about, but I'd give my very best 3D. So what should we do? Repair, replace, transplant, or do the assist device? So where should I do this? Yeah. Should I go on? No disclosures. So what it comes down to is pretty much the hen or the egg question, right? Is it the mitral regurgitation that triggers left ventricular enlargement, or is it enlargement of the left ventricle, enlargement of the mitral annulus, and then coaptation deficit? Then that would even enlarge the left ventricle more. If it's the mitral, it's easy. You can repair, we can replace. If it's the ventricle, and we think about dilative cardiomyopathy, it's most likely the ventricle. It's much more difficult to decide what to do. Of course, it would be better if the valve would be closing, but then if the heart had an ejection fraction of only 20%, would he be still able to get enough forward flow if the regurgitation volume is beforehand 50%, which means severe mitral regurg? Difficult questions, and I just tell you how I approach this question. First, I asked my adult specialists, because they have a lot of these patients. I want you to look with me to the ESC guidelines. Then transcatheter edge-to-edge repair is something we have to think about. And then, of course, transplant and different types of assist devices. So this is our specialist for assist device. Evgeny Potapov, he he's crazy about putting assist devices every week, 2 at least. So what does he tell me? He tells me scores don't work. I will see them all anyway, which is a pretty fatalistic way, and but pretty much resembles my experience. But then I said, well, there must be a more sophisticated answer to this question. I have to tell you. So I asked Axel Unbehauen, who does all the TAVIs and the mitral clips in our institution, quite a lot of experience, and tells me there are some who will respond to the treatment. It's evaluated by the heart team, and this will generally follow the ESC guidelines. So how are the ESC guidelines? Of course, in dilated cardiomyopathy or ischemic cardiomyopathy, the mitral leaflets and chordae, they are generally normal. There's nothing we can do about this. And then the mitral regurgitation basically results of an imbalance of closing and tethering forces secondary to alterations of the left ventricle and the left atrium. And this with severely dilated left ventricle, with impaired ventricular function, or almost normal sized ventricle with normal function. When we have inferior posterior myocardial infarction with posterior leaflet tethering, or atrial functional mitral regurgitation, that's when we have a left atrial and mitral annulus dilatation in case of long-standing AFib. So the management strategy is pretty straightforward. Patients must have symptoms, and this despite guideline-directed medical therapy, and so they should be transferred to the heart team. The heart team will then decide whether they can optimize, improve medical therapy or put a CRT according to guidelines. They will judge whether there's comorbidities, or whether the life expectancy is less than 1 year, and then sent to palliative care, or then address other cardiac anomalies or coronary disease. So the next step is then either, if they are appropriate for surgery, they would be having combined surgery, or if they are not, then they would have PCI or TAVI procedures and then looked after, and if the symptoms are no longer severe, then they would go to have a close follow-up. And of course, if the symptoms remain, then they would have to have, and they would be appropriate for surgery, they would have surgery. So that's clear. So if they're not appropriate for mitral surgery, what to do? Well, then they would be addressed to have, and would have end-stage left or right ventricular failure. They would be considered to have a transplant or assist device or palliative care. But now the interesting part begins. This is when we reach level 2 evidence, B to C level. That's the patients in between. So what should we do in that? So if they fulfill criteria, and you see how that's been formulated, suggesting increased choice of responding to transcatheter edge-to-edge repair, they should have this. So that would be saying, well, they should be having an increased survival, less hospitalization rate, less MR. But then there's these patients who wouldn't be expected, they just improve the symptoms. So that's the in-between section, and we have to have a close look on that patients. So who is fulfilling criteria suggesting increased chance of responding to TEER. But first of all, we have to discuss about what is severe MR. And of course, I'm not the specialist, maybe you are the specialist or the magnetic response, or MRT specialists are giving us good results. If you have the echo parameters, you have qualitative, semi-quantitative, or quantitative parameters. I want to focus just on these three because they are mentioned in the guidelines. So effective regurgitant orifice area, regurgitant volume, regurgitant fraction, these three. And now, as you might better how to calculate them, I think it's important that there's a calculation of peak velocity and flow, and then you have somehow can calculate the area, and this should be should be above 0.4 square centimeters to say, well, that's a severe mitral regurgitation. And you would have then a regurgitation volume of more than 60, regurgitation fraction more than 50. Well, then that would be a severe mitral regurgitation. But the problem is there's an inter-observer variation. Jets may be eccentric, orifice may be crescent shape, and of course, regurgitant orifice area and regurgitant volume is dependent on end-diastolic volume, peak velocities, and ejection fraction. To make it even a little more complicated, but I think that's very depicting. If you have a, let's see whether, if you have a volume, end-diastolic volume of 250, with an ejection fraction of 30, regurgitation fraction of 50, and you don't reach a peak velocity of, say, you have only a peak velocity of 4, then you cannot reach a regurgitant orifice area of more than 0.3. So that's a problem. And also, if you see different ejection fractions, 20, for example, if you have a large ventricle, you will never reach a regurgitant volume of 60, which is basically depicting a severe mitral regurgitation. So there is some uncertainties. Maybe it would be better with MRT. But so how do we define the increased chance of responding to TEER? Well, there are studies, of course. There's 2 randomized controlled studies. Both included severe symptomatic heart failure patient with severe mitral regurgitation despite optimal medical therapy, not appropriate for surgery. So what do they find out? There's a co-op study, 600 patient, American study, reduced mitral regurgitation up to 3 years, and reduced all-cause mortality and hospitalization for heart failure at 2 years, so TEER beneficial. French study, 300 patients, and they looked at it and said, well, no impact at all, nothing. TEER, not beneficial. So what's the difference between these 2 studies? They all included the same patients. Well, if you look at the effective regurgitant orifice area, you can find in the co-op studies severity of MR is greater and there's less dilatation of the left ventricle. So in one study you have a smaller LV, larger MR, a disproportionate mitral regurgitation. In the other study you have a larger MR and a larger LV and smaller mitral regurgitation, a proportionate mitral regurgitation. So to give you an idea, if you look at these 2 pictures, you would find the same ejection fraction, 30%, same regurgitation orifice area, 0.4, same regurgitation fraction, but then you would have different end-diastolic volumes, and then you would have a proportionately severe MR or a disproportionately severe MR. This would respond to TER, and this only to optimization of medical therapy, and then assist or transplant. Over here you can see that the relationship between end-diastolic volume and effective regurgitation area, and you can see the gray area, which is the area of proportionally severe MR, in which the MR is consistent with LV dilatation. And then you can find the green area below the line of proportionality, where you basically find no severe MR. And then you find the red area. The red area would be the area of disproportionately severe MR, when you have the MR compared with the LV enlargement is more pronounced. They will benefit to TER. So if we reach the gray area and we cannot do anything for the patient with respect to the mitral valve, such in many patients that we see, younger or older, especially in the grown-up congenital heart, if we find them, and then if they are listed, they should follow this criteria. They would have New York Heart Classification 3-4. They would major limitation, daily activities. They would have exercise testing of with a VO2 max of less than 14 and a prognosis of less than 75%. So what should we do then? We list them and then we wait, and we wait, and we wait, and we wait. And that's the usual scenario in most of our patients, and then we're waiting too long. And then patients got in hospital, decompensation, and we put them on inotropes, but they have another organ failure, which is not improving, and so we have the indications for mechanical support. And there's the other organ systems that are failing are just listed. But basically what it comes down to, we give another inotropic support, and this will just keep them stable, but the central venous saturation is below 60. So we basically reach the Entermax-2 sliding on inotropes, and we hope that the right ventricle is still good enough so that we can just put a left ventricular assist device. What different types of mechanical support do we have? Well, if they are in cardiac arrest and pulmonary failure, they would have an ECMO first. And if we think, well, it's a condition that would resolve maybe in 1 to 2 weeks, like an acute rejection, we would put an impeller or ECMELA, and I will go into deeper to that a little later, how we do that. If we think about a cardiomyopathy or chronic heart failure in congenital heart or dilated myocarditis, we rather go and put a long-term survival, which is a Berlin heart, to 20 to 30 kilograms if they're below that. And if they're above, depending on the chest size, we can put a HeartMate 3. That's how we do the ECMELA. First of all, we try to get down to the subclavian artery, put a graft, and then put the shunt and a side arm. We can put a 15 French arterial cannula, and either use the femoral vein or the jugular vein when we want to mobilize the patient to do the to go on bypass. This is the smallest kit we put on impeller. This is 3 years old, 12 kilogram with the acute humeral rejection. We put a 2.5 impeller. I think that's not currently longer available, but we are lucky to have the last one. Could do that and put them from the ventilator after 8 hours, did a plasmapheresis, and then weaned the patient 8 days after support. So talking about results of the XCOR Pediatric, just a quick overview, it's between 60 and 80% survival, and you see the It's best, of course, in cardiomyopathy and myocarditis. And the blue columns basically say that they are transplanted. There's the green bits, it's weaned from transplant. You can see the postcardiotomy and myocarditis, and the overall Berlin heart experience is is about 15 to 20%. At the Berlin heart, we have much longer waiting times. That gives the heart time to recover. So we have, for myocarditis, have up to 70% of recovery and then weaning. But also we have about 20 to 30 in other conditions, like in congenital heart diseases or in cardiomyopathy. Risk factors for mortality for XCOR are listed in this study. It's earlier implantation, lower weight than 5 kilograms, congenital heart disease, pre-op ECMO or biventricular assist device. And if you look at the outcomes of the heart transplant, that's been done by this very large study, 30 years, you can see that the early outcome of infants is worse, but then probably because there's less rejection, and the long-term outcome is much better. But heart transplant, and you have to tell the parents, it's not a lifetime solution. As you can see, the outcome of 30 years is only 20%, so they have to be retransplanted at some stage, whether they're infant or pediatric. Just the conclusion of this topic, mitral regurgitation in dilated cardiomyopathy, you have to have a close look. I think that's very important. It's never the mitral alone. If that's the case, and it's a disproportionate mitral regurgitation, you can actually go for repair, replacement, or transcatheter replacement, depending on the patient. If it's proportionate mitral regurgitation, and this could be severe too, it's the ventricle, and there's no meaning about replacing the valve. You have to go for VAD or transplant if the clinical condition is like that. You cannot improve these patients by just changing the valve. I showed you a little quick outcomes of LVADs, which in kids is quite good, with a weaning rate of about 20%. We were not able to wean from the bypass. If it's after 4 months, they will not recover. But it's much better with myocarditis, up to 70 rates. That's results that Americans never see because they transplant much earlier. We have worse outcomes with small kids, with BIVAD and ECMO support. Transplant outcomes is I think, reasonable, excellent for cardiomyopathy, and also for congenital heart disease. A little bit worse for VAD procedures. Yeah, that's basically it. I would like to thank you again to be invited here, and I'm happy to get and receive your questions.